tes.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Assalamualaikum. Boleh dengar ya?
Waalaikumsalam, boleh.
Nampak ke slide?
Assalamualaikum. Boleh dengar?
Boleh, Doktor.
Okay, kalau dengar boleh start. Sorry, I just came back from an emergency. I tak dengar suara you lah.
Hello, Doktor? Dah dengar ke? Yes. Hello. Assalamualaikum. Tak dengar ke, Doktor? Hello. Hello.
Not sure why I can't hear you lah. Mana? Hello?
Boleh. Kamu boleh dengar, Doktor.
Not sure why tak dengar you lah.
Hello. Hello, Doktor boleh dengar?
Assalamualaikum.
Yes. Doktor.
Ya, sorry. Tadi I tak boleh dengar suara you lah. Firstly, apologize sebab baru balik dari emergency. I think kita boleh start lah.
Boleh start.
Assalamualaikum.
Yep.
Assalamualaikum warahmatullahi wabarakatuh. I was supervisor Dr. Salehin and also all my fellow friends. Let's start with Al-Fatihah. Okay, so tonight we will present on the space seminar 4, which are child who is constipated, child with generalized edema, child with change of urine color, and infant who born inactive. Next. Okay, my name is Fazil Zinira binti Fazil, 1717464, and I will present on the topic child who is constipated. Okay, next. Okay, so let's we go through the anatomy of the gastrointestinal tract. The GIT started from the oral cavity and it will end with the rectum and anus. The liver, pancreas, and gallbladder will directly communicate with the GI tract by the ducts that will join with the duodenum. So in the oral cavity, the oral cavity is relatively small. They have a short, wide, and thick tongue, and the muscle of the lips are well developed. And then they also have a buccal fat pads in the cheeks. They will become atrophy at 4 years old. The membrane of the bladder is also thin, reaching the blood vessels, so it easily vulnerable. And they have a poor development of the salivary glands, which will develop at 3 to 4 months old. And then in children, they have a short and also narrow esophagus with low development of the muscle and elastic tissue and tumors. The entrance of the esophagus are also highly located between third and fourth vital vertebra, and by 12 years old, it is located between 4 to 7 vertebra. For the stomach, they have low functional volume, and it will be increasing by the age. So like at birth, the volume is 7 ml, at 10 days, 80 ml, at 1 years old, 150 ml, at 3 years old, 100 to 600 ml, and at 10 years old, 1.3 to 1.5 liter. And at an early age, the stomach is in horizontal position, and by the year the child begins to walk, the stomach gradually adopts the vertical position. They also have poor development of the fundus, cardiac, and muscular joint. For the pancreas, it is underdeveloped to the birth, and there will be intensive growth up at 3 years of age, and also in puberty. There is also poor development of the connective tissue, and the lobulation will be at risk by 10 to 12%. The liver is relatively large size, and there is a poor development of the lobular structure and connective tissue. And for the gallbladder, in infants, it is hidden behind the liver, small size, and the fundus is covered with peritoneum. Next. So next is the small intestine. The length of the small intestine in newborn is relative to the body length is longer than adults, and the lips are also like more compact than adults because of the relative large size of the liver and also the underdevelopment of the small pelvis. The duodenum is in circular form and located at the level of L1. Meanwhile, the jejunum, it takes about 2/5 small intestine length. The mucous membrane is thin, rich with blood vessel, and has enhanced permeability. It also has many cases, but the volume will be gradually decreased to 7 years old. In the ileum, it takes about 3/5 small intestine length, and it will end in the inner circle. For the large intestine, the length in the newborn is 63 centimeter, and by the end of 1 year old, it will increase to 83 centimeter. The epiploid epididymis will form at 2 years old, and haustra at 6 months old. In the rectum, it is cylindrical in shape, and they have relatively long and also back peaks because of the fat tissue is underdeveloped, but it will take the final position to 2 years old. The muscle tonic is also fully developed. They have well developed submucosa, but weak fixation of the mucous membrane. So the child can have also can have rectal polyps, and there is a relative underdevelopment of the sphincter of the anus. Next. So let's we go on the physiology of the large bowel. So the large bowel function mainly to absorb the water and electrolytes, to form and propel the feces toward the rectum for elimination, and also to produce and absorb the vitamins in the absorption of the water and electrolytes. The absorption of the water is occurred by the osmosis, and in response to the gradient that created by the absorption of the electrolytes, mainly the sodium is actively absorbed in the colon by the sodium channels, and as this movement of the sodium into the plasma will produce the gradient, they will allow the oxygen of the chloride, and they will be exchanged with the backup. Meanwhile, for the potassium, it may absorb or it may be secreted, depends on the concentration in the lumen. As elimination of the pieces, it involves two types of motility, which are house roll contraction and mass movement. In house roll contraction, so the house roll are the saccles in the colon that will give the segmented appearance, and this contraction will be activated by the KINE. And on the colon wall, there are pacemaker cells that will send the signals to the smooth muscle cell, so it will cause contraction at the regular intervals. So this contraction will cause the propulsion of the pieces towards the anus by the gentle progression. So it will cause the pieces to move slowly to the next house roll, and besides, it will also mix the fecal material to help with the water absorption. And then the other motility is by the mass movement, which it involves a sudden and also uniform peristaltic contraction of the smooth muscle. And so it will rapidly move the pieces into the rectum. And this result for the feeling the urge to defecate. And besides, this contraction can be stimulated by eating. When this occurs, it called as a gastrocolic reflex. And the last one is the production and absorption of vitamins. At first, the colon is dry, and the colonic bacteria flora will establish early in life. So the colonic bacteria will produce vitamin K, vitamin B, and also biotin, and then it will be absorbed into the blood. Next. Okay, so the room 4 criteria is the most accepted criteria to diagnose the childhood constipation. So let's go on the infant and toddlers up to 4 years old. They need to have at least 2 of these following presentation for at least 1 month, where there is 2 or fewer defecations per week. There is a history of the excessive stool retention, history of painful or hard bowel movements, history of large diameter stools, and then presence of large fecal mass in the rectum. In the toilet trained children, we may there is an additional criteria, which at least there is 1 episode per week of incontinence, and also a history of the large diameter stools that may obstruct the toilet. And then in the child with developmental age more than 4 years old, they need to have at least 2 of the following for at least once per week in at least for at least 1 month. So the criteria just the same with the infants and toddlers below 4 years old, but with the addition of history of retentive posturing or excessive volitional stool retention. As you can see in the picture above, so the retentive posturing is when the child has like straight leg on tiptoes or clenched buttocks with back arching, and it can be mistaken by parents as straining open. And for the excessive volitional stool retention, it is described in the older child, where they withhold their stool without necessarily displaying the retentive posturing. And the criteria in the children up more than 4 years old, the symptoms are insufficient to fulfill the diagnostic criteria of irritable bowel syndrome. Next. So in the history, we should ask about first the frequency, consistency, and also the size of the stool. As the normal bowel movement frequency, more likely to be irritable bowel syndrome, and then the large hard stools may be sign of the withholding, and then the age of the onset. In the infants who is younger more than 1 month have a likelihood to have organ etiology. Then we should ask about if there is any pain or bleeding with passing stool, because it indicates that the stools are hard enough to produce the fissure, or it can be associated with allergy. Then ask about any abdominal pains, the timing of the first movement after the birth. So normally the newborn should have should pass meconium within first 24 hours of life. So if there is lack of the bowel movements, might suggest for example like his lung disease. And then ask any fecal incontinence. It can messages frequent infection. And then withholding behavior, because it also can contribute to the constipation in young child. Any systemic symptoms, for example, like fever, vomiting, loss of weight, and also decreased appetite, because it may indicate any organic etiology, for example, Crohn's disease. Any social history, ask about toilet training as well as stress. So in the child who is in toilet training, they can have like a fear pooping in the toilet, or fear of emotional pressure to use the toilet, or to give up on diapers. And for some little children, the sensation of the feces that falling away from the body over toilets can be strange and so scary, and it can be difficult for children to relax and sit still for a amount of time more than 30. So this can cause the child to avoid defecate, and they can, so when they avoid defecate, so they can become constipated. And then if they seek for treatment, so we ask if there is any current and previous therapies, and also assess for adherence and effectiveness of previous and current treatments. Next. Then we should assess for any red flags which suggest the organic cause of constipation. So the red flags include if the onset before 1 month of age. So it may suggest the congenital malformation of aneurysmal spine, H. disease, allergy, or metabolic or endocrine condition. Then any delayed passage of meconium, more than 48 hours afterward, failure to thrive, abdominal distension, then intermittent diarrhea and explosive stool, empty rectum, gushing of stool with rectal examination, and also tight anus sphincter. Next. So the other red flags, so we do the physical examination. So look for any plain of the dimple that covered by tuft of hair, any pigmented abnormalities, and also abnormal urological examination. So that might suggest for spinal cord abnormality. Then any occult in stool, extraintestinal symptoms, for example, like vomiting, fever, and also ill appearance. And then if there is no history of the crowding or swelling, and no response to the conventional treatment. Next. So the differential diagnosis for the constipation. So the first one is functional constipation. So the clinical features it should be made with the wrong criteria. And then second is anatomic malformation of the colon and rectum. For example, like imperfect anus. So the child can have a failure to pass meconium in 24 hours of life. There is abdominal distension. Then on physical examination, maybe we can see the fistula, and there is a meconium that emerged from it, and there is a lack of an opening. So we can do MRI, ultrasound, and X-ray to determine the internal extent of the defect. And then third is the spinal cord abnormalities. For example, meningomyelocele. So we can see that there is a protrusion into the skin at the back. Then the child can present its paraplegia, and there is no control on the bladder and bowel. So the meningomyelocele can be diagnosed antenatally on ultrasound on second trimester, where there is a concavity of frontal bone, hydrocephalus, and cherry-two malformation. So the cherry-two malformation is when the cerebellum, brainstem, and also the post-ventricle is emerge into the is extend into the foramen magnum. And then spinal cord tumor. So the child can have loss of coordination in arms or legs, and then numbness and weakness. So we can do MRI to look for any focus in alteration with cord extension, and also its response to the contrast enhancement. And then tethered cord, the child can present with lower back pain, any feet or leg deformities, and then lower extremities sensory or motor changes. So we also do MRI, and then we can see that there is an abnormally low spinal cord and also fatty infiltration. Next. So the metabolic conditions also can cause the child to have constipation. For example, like hypothyroidism. So they may have delayed development, short stature, and so again. So we can do the thyroid function test. There will be low TSH and TSH. Then diabetes mellitus. So the child can present with polyuria, polyphagia, and polydipsia, loss of weight, fatigue, and also weakness. On the investigation, we do fasting plasma glucose, and it will be, and the reading would be 7 or more millimole. And also diabetes insipidus. the child can present with polyuria, nocturia, and polydipsia. And we send for serum and urine osmolality. Where in the serum, there will be high serum osmolality and low in the urine osmolality. Then other DDX is neuropathic gastrointestinal disorder. For example, like H-sprung disease, where the child can present with failure to pass meconium within the first 24 hours, abdominal distension, and also bilious vomiting. So these are presentation in the neonates. Meanwhile, in the children, they can have chronic constipation, abdominal distension, and also ghost failure. So on abdominal X-ray, there will be dilatation of the bowel, and we also can do the rectal suction biopsy, where there will be absence of ganglion cell in the submucous plexus. And then the drug use for toxin exposure also can lead to the constipation. For example, like anticholinergics, antacids, antidepressants, antihypertensive, and also lead toxicity. So we can do the blood test to look for the if there's any evidence. Next. Okay, so other systemic disorder, for example, like celiac disease. So typically, the patient will present with chronic diarrhea, abdominal distension, of pain, vomiting, failure to thrive, and also loss of weight. But in the late childhood, they can have atypical symptoms. For example, like chronic constipation, short stature, and also arthritis. So we can order for serological tests. They will be positive anti-tissue transglutaminase antibodies. And then we also can do the duodenal biopsy. There will be bilious atrophy. And then in the cystic fibrosis, in the neonates, they can present it with the meconium ileus, which meconium ileus is when there is complete obstruction by the accumulation of the meconium. Therefore, the neonates can have failure to pass the meconium in 12 to 24 hours, abdominal distension, and also bilious vomiting. So we can order for the sweat test. There will be a high chloride concentration. In the teenagers, in the teenagers with cystic fibrosis, they can have constipation, which there are criteria constipation in the cystic fibrosis, which they should have abdominal pain or distension, or reduced frequency of bowel movement in the last few weeks or months, or increased consistency of stools in the last few weeks or months, and symptoms relieved by the and this need to be differentiated with the distal intestinal obstruction syndrome. And in the IOS, they will have bilious vomiting. So we can order for abdominal X-ray. So in the constipation, the faces will be appeared throughout the colon. And while in the IOS, the faces will be, the fecal mass is in the ileocecal. Next. Next is the Bristol stool chart. So the Bristol stool chart can help us to classify the stool into the 7 groups, which are type 1 and also type 2, that indicates that there is constipation. Like in the type 1, the stool is described as separate and hard lump, and the type 2 is lumpy and sausage lump. And the type 3 and 4 is normal and easier to pass. Type 5, 6, and 7 indicate the diarrhea. So I think that's all for the child.
All right, very good. I think very, very good. We will move on to the next one before we have Q&A session. We have Q&A session at the end. Okay, move on to the next one.
My name is Ayuni. I'll be presenting the next topic, which is a child with generalized edema. So first, the definition of edema. Edema can be defined as the presence of excess fluid in the interstitial space of the body. So there's two types, which is localized and generalized. Localized, for example, ascites and pleural effusions, and generalized is anasarca or severe generalized edema. Okay, so this is the Stalling law of the Stalling equation about what determines the flow of substances through the capillary. So there's two types of forces, which is hydrostatic and oncotic forces, which is present inside the capillary and also at the interstitial. So any imbalances to any of these, for example, increase hydrostatic forces or decrease oncotic forces, will force fluid to go outside of the capillary. All right. So this is the pathophysiology of edema, can be divided into three. So first is increased capillary hydrostatic pressure, which pushes the fluid outside of the capillary. An example is increased plasma volume, which cause sodium and water retention. For example, in heart failure, what happens is that there is a reduced effective circulating blood volume. So when the body detects that, it will activate the RAAS, the RAS system, which causes sodium and water retention, which ultimately causes an expansion in plasma volume. And for renal disease, for example, acute glomerulonephritis, similarly, but what's different is that in AGN, there is a destruction in the capillary, in the glomerulus capillaries, which causes decreased filtration of the sodium and water itself, which is why there is an increased plasma volume causing edema. And then for decreased capillary oncotic pressure, which is caused by hypoalbuminemia, an example is nephrotic syndrome. So because of proteinuria, patient will have hypoalbuminemia, causing reduced oncotic pressure, which is why the water will be pushed out of the capillary, causing edema. Other examples of that are liver failure and protein malnutrition. And then another one is increased capillary permeability, which will cause a localized edema, for example, burn or sepsis. Okay, so next we go to history taking, HOPI. So the swelling itself of the edema, so we have to ask about the specific site. Is it at the leg, or is it unilateral, bilateral? The onset, the progression of the swelling, whether it's painful, which may indicate, for example, cellulitis or DVT. Redness, relieving or exacerbating factor, if it's better at the morning or evening. Is there any previous similar presentation before? And then other associated symptoms include fever, lethargy, vomiting, dizziness, and headache. So we have to ask about the symptoms of hypovolemia, for example, abdominal pain and oliguria. Next is shortness of breath, which may be caused by pleural effusion or pulmonary edema. There might be rashes, which may point towards the etiology of renal disease, for example, SLE. Next, if there is any hematuria in glomerulonephritis or fatty urine in nephrotic syndrome. So we have to ask about symptoms of heart failure, for example, paroxysmal nocturnal dyspnea, orthopnea, and cyanosis if there is any congenital heart disease in pediatric population. So we have to ask about abdominal distension, yellowish discoloration of the skin, or steatorrhea, which may point towards a hepatic diagnosis, or if there is any history of seizure, which may happen in hepatic encephalopathy. Next, other important history. Is there any history of burn before? Any past history of sore throat or skin infection, which may cause a post-streptococcal glomerulonephritis? Past history of recurrent urinary tract infection, which may cause a kidney infection now, or any history of blood transfusion, which may give a patient infection, for example, Hep B or Hep C. So past medical history, we have to ask patient about any underlying medical illness, mainly congenital heart disease, IgA, SLE, and HSP. So if there is any family history of renal, heart, or liver disease, drug history, and feeding history, because patient may be malnutrition, or there's any feeding difficulty, for example, manifested by poor sucking, prolonged time to feed, sweating during feeding. So patient might be malnutrition. Okay, next is physical examination. Generally, we have to assess whether the patient is alert, conscious, or in any distress. If there is any skin rash, check for any JVP at the neck, which may happen in patient with nephritic syndrome. Check for hydration status, features of hypovolemia, for example, whether the periphery is warm or cold, the CRT, whether the patient is anemic or not. We also have to check for genitalia, for scrotal or labia majora swelling. Check for the lower limbs, edema, and make sure if it's pitting or non-pitting edema. We also have to check if there is any Cushingoid features in patient, because patient might be a known case of nephrotic syndrome. It can be on long-term steroid. So we have to check for cyanosis, anemia, jaundice, or any stigmata of infective endocarditis or liver disease. Next is vital signs. So we have to check BP because patient can be hypertensive or hypo. Hypertensive can happen in nephritic syndrome because they are fluid overload in intravascularly. And hypotension can occur in nephrotic syndrome because of third spacing of fluid loss. Next is respiratory rate. Patient can be tachypnic because of pleural effusion or pulmonary edema. Check for the pulse rate. Patient can be tachycardic because of hypovolemic shock. A patient may also be feverish because of infection. And then for anthropometric measurement, it's important, especially the weight of the patient. Maybe patient are failure to thrive because of malnutrition, or a patient might actually gain weight because of the fluid inside the body. Next is respiratory examination. We percuss for any stony dullness, which indicates fluid, and we auscultate at the bases for any pulmonary edema. And then for cardiovascular examination, check for murmurs in patient in congenital heart disease. For abdominal examination, if there is any gross ascites or abdominal distension, or any caput manusa, which is stigmata of liver disease. We palpate for hepatomegaly, or if there is any palatable kidney. And we percuss for fluid trail or shifting dullness, which may be present in generalized edema. And then we check for neurological examination to complete. Okay, next is pitting versus non-pitting edema. So the difference is that when you examine a pitting edema, so there will be a pitting area. And the difference between the two is that the composition of the fluid itself. So pitting edema is mainly transudate, which is fluid mainly composed of water, but non-pitting edema, because it's associated with conditions affecting the thyroid or lymphatic system. So the buildup composed of proteins, salt, and water. So when you press at the patient of a patient with non-pitting edema, so because of lymphatic obstruction, for example, lymphedema, or because of myxedema, so the fluid wouldn't get absorbed into the lymphatic system, so it would rapidly fill up the area that you press. But in pitting edema, because it's mainly fluid and the lymphatic system is intact in this patient, so when you press, there will be an area of pitting because the fluid goes somewhere else. Then this is the differential diagnosis of edema based on the pathophysiology. I'm not sure if you can see because it's very small. But the ones that we want to focus about is, for example, in increased capillary hydrostatic pressure, there is a renal failure, glomerulonephritis, and CHF. And then there's decreased capillary oncotic pressure, for example, nephrotic syndrome, liver failure, and there is a patient with malnutrition. In increased capillary permeability, patient with sepsis, burn, anaphylaxis, and other differentials. But we will focus on a few of them. So for example, in nephrotic syndrome, the clinical features, the edema is much more pronounced compared to other diagnoses. So patient can have proteurine, or patient can also have oliguria, especially in a hypovolemic patient. But usually there is no hypertension in this patient. So what we can expect in investigation, patient might have increased hematocrit because of hypovolemia, causing hemoconcentration. So patient may also have proteinuria, but the difference between nephrotic and glomerulonephritis is that proteinuria in nephrotic syndrome is much more enhanced. It's in the nephrotic range, which is 3 to 3.5 gram per day in a 24-hour urine protein. In contrast, for glomerulonephritis, it's around 0.5 gram per day, much less. And then we check for UF and EME. In nephrotic syndrome, you can have fatty casts, but in glomerulonephritis, you might be able to see red cell casts because of microscopic hematuria. And then liver function test in nephrotic syndrome, you will be able to see hypoalbuminemia. And for in order to compensate for the hypoalbuminemia, patient may have hyperlipidemia. And then renal profile in both nephrotic and glomerulonephritis, both may show AKI, but it's more prominent in glomerulonephritis. And then chest X-ray may show pleural effusion because of third spacing of the fluid. So next is glomerulonephritis. So clinical features, there is hypertension because of increased intravascular volume because of the pathophysiology. And then serum complement will show low C3 or C4 in these patients. And other differential diagnosis, for example, congestive heart failure, patient will present with shortness of breath, which may be paroxysmal nocturnal dyspnea or orthopnea. Patient may also have edema and lethargic. So that the diagnosis, investigation, in chest X-ray, we will be able to see a cardiomegaly and pulmonary edema. ECG, same thing, and echo, we might be able to see reduced ejection fraction, and also any structural abnormalities. And liver cirrhosis, patient may present with jaundice or edema, and liver function test may show deranged liver enzymes and high bilirubin. And serologically, this patient might have Hep B or Hep C. That's all from me.
Okay, all right. We move on next presentation.
So I will be the next presenter. My name is Neonis Kazlin binti Kamaruzi, metric number 1715598. I will be present about the child with change of urine color. Next. So the urinary system consists of the two kidney, two ureter, one urinary bladder, and one urethra. And the kidney is a urine forming organ, while the others are the structure that carry urine from the kidney to the outside via excretion. And the nephron is one functional unit of the kidney, consists of vascular and the tubular component. So we know that vascular component, which is vascular, efferent arterioles, glomerulus, and also peritubular capillaries. While the tubular component, we have Bowman capsule, loop of Henle, proximal and distal tubule, and also collecting duct. And other component is that juxtaglomerular apparatus, which is a combination of the vascular and the tubular component, which mainly the function is mainly on blood pressure regulation and glomerular filtration rate. Next. So how does urine form? Is from the three process, which is filtration, reabsorption, and secretion. So filtration is when water and solid other than protein forced into the renal tubule. While the reabsorption, when water, glucose, minerals, ions, and any wanted molecules transport back into the blood. While the secretion, the unwanted solutes like creatinine, drugs secreted back into the urine. So the normal urine usually clear, no turbidity, light yellow, and almost colorless. So a very good normal urine is a clear water, clear urine. And the pigment, in the urine is from the urobilinogen, which is give you yellow pigment. And the darker the urine, the concentrated the urine is, and shows that the hydration status of the patient. Next. So the causes of the dark color urine vs hematuria. Under dark color urine, we have dark yellow, dark brown, red, or pink. For the dark yellow, usually a normal concentrated urine. For the dark brown, it is signified one of the causes could be there is increase in the bilirubin that come from the red blood cell breakdown. Can be caused from the hemolysis, liver disease, post-hepatic obstruction. Others like melanin, usually it is not present in urine, but it can be produced when there is a melanoma in the liver, such as in the liver. Others are metamoglobinuria, which is when there is presence of metamoglobinemia in the blood, which is one form of the abnormal hemoglobin that we bind to the ferrum 3+ instead of 2+. Thus, it can cause a patient to have cyanosis too. This metamoglobinuria can be caused of many drugs such as chloroquine. Next is red or pink. So one of the causes can be myoglobinuria, which is usually the result of rhabdomyolysis or muscle destruction, releasing a high amount of myoglobin in the blood. This myoglobin can cause acute kidney injury that we have to check the creatinine level next. Other causes could be porphyrin. Porphyrin is a water-soluble metallic ring molecule that has ferrum 2+, which is one of the example is the heme molecule. Others like drug and also red dye. Chloroquine is one of the example that can cause metamoglobinuria yang tadi. Others example deferoxamine, beets, blackberries, rifampicins, urates. Other color that we have is tubic urine. One of the causes could be proteinuria, lipiduria in the nephrotic syndrome, and then chyluria. Chyluria ni is a condition where there is a lymphatic fluid leaking into the kidney. One of the causes could be from the parasitic infection like filariasis, and then the cell like pyuria and bacteriuria. And lastly is crystallization like in calculi, uric acid and calcium oxalate. For the hematuria, which is we can divide it into the grossly and or microscopic hematuria, or it can be confirmed by the deep slit test. So hematuria is when there is presence of blood in the patient urine, and it can be causes by any organ along the urinary system. It can be divided into glomerular and non-glomerular. So I think that's this disease is you guys familiar with, and the common hematuria causes of hematuria in the pediatric usually post-strep glomerular nephritis, Alport syndrome, IgA nephropathy, polycystic kidney disease. Others causes of hematuria like menstruation, which can give false hematuria. I think on next. I would like to explain about the intra and extravascular hemolysis in relation to the urine color. So normally, red blood cell is phagocyted by macrophage extravascularly, and giving the last product of unconjugated bilirubin, which is non-water soluble. Thus, it conjugated in the liver, become the water soluble, and then next become urobilinogen, which then secreted into the urine, giving the yellow pigment for the urine. But the patient that have a liver condition like liver disease, post hepatic obstruction, can have increase in conjugated bilirubin that also can give dark color urine. But for the extravascular hemolysis, there will be increase in phagocytosis of the red blood cell in the reticular reticular endothelial system, like liver, spleen, and also lung. Why this happen? For example, in the hereditary spherocytosis, the red blood cell has abnormal shape like sphere, so it has difficulty to pass through this system, thus causing hemolysis by this organ. Thus, it explains why the dark color urine solely because of the macrophage killing more red blood cell because of the abnormal shape. For the intravascular hemolysis, when there is it is by its name. So when there is an increase in breakdown of the red blood cell, increase of the hemoglobin in the urine, in the blood, increase in hemoglobinemia, thus secreted in the urine, become hemoglobinuria. So usually in the acute hemolysis episode, there is no bilirubin because of the increase of hemoglobin. So there is no bilirubin. But along with the time, there is increase in production of the conjugated and conjugated, then as well as urobilinogen. So this explains why the intravascular have more intravascular hemolysis. The urine have more hemoglobin, thus give more redness. For extravascular hemolysis, give because the red blood cells still phagocyted in the liver, thus give the there is a conjugated bilirubin, it does have give dark color urine. So which one do you think is the intravascular and extravascular urine? The red one is the intravascular then. Okay, next. So the investigation, for the patient that we want to do a urine test, or any patient that has abnormal color urine, so we can do the test as simple as urine dipstick test. So from the urine, we can have cuba tekan sekali lagi. We can have a lot of information from the urine dipsticks, like specific gravity, pH, leukocyte, any blood in the urine, nitrates, ketone, bilirubin, urobilinogen, protein, and also glucose. And other investigation that we can do is the UFEME, urine full examination and microscopic examination, where we want to examine the urine under the microscope. Next slide. We want to know if there is red cell in the urine, there is CAS, there is not bad cell. Hyaline CAS is a normal CAS. Everyone can have that. Granular CAS can indicate that there is degeneration of the cell in the kidney. That may signify any kidney disease. Red cell, red cell CAS, we can kind of know that the origin of the bleeding from the glomerular higher up. And any crystal in the blood, like for example, bilirubin crystal, we can see the. Okay, next slide. So so as I said earlier, from the UFME, we can examine the urine under the microscope. Thus, we must examine the size or the shape of the red blood cell, whether there is presence of the CAS or not, and whether there is proteinuria or not. Thus, we can categorize the causes. So, for example, like in glomerular, we can do the test to diagnose the glomerulonephritis. I think the other test you guys are already familiar with. Next. So this is the difference of lab evaluation of the hemolysis between extra and intravascular. So for the urine, from the urine, we can see that for the intravascular, there is presence of hemoglobin and hemosiderin. Bilirubin, both are present. For the plasma, both have unconjugated bilirubin. For the hematological, we can see that both have increase in the red blood cell formation, as well as reticular formation. For the plasma, we can see that there is unconjugated bilirubin. There is absence of haptoglobin. Haptoglobin is a protein that will bind to the free heme. So when there is hemolysis, there will be free heme and free globulin. So heme will be bind to the haptoglobin. So there is a decrease in the haptoglobin. Plasma hemoglobin and then lactate dehydrogenase is one of the content from the red blood cell. Thus, it will increase in the plasma if there is hemolysis. Next, I think that's all for me.
Okay, all right. This is a common question that you be asked. I think the intravascular hemolysis and the features of the urine. So I think revise back what your friends have present, and I think it's a very common topic that you be asked in written and also in clinical. Okay, we move on to the last presentation.
Okay, so so I'm Mustafa Samba. So I'll be presenting on infant born inactive. So infant born inactive, it can be the child present with depressed respiration, or the child present with not crying after birth, or whether the patient can present with depressed in muscle tone or hypotonia. Okay, so in every child that was born, we have a scoring system that we use, which is commonly used. We use ABGA score, which composed of 5 elements, which is appearance, pulse, grimace, activity, and respiration, where these 5 components, which will give the score of 10. So for the classification, we can the normal ABGA score is 7 and above, whereas 4 to 6, which is fairly low, which require monitoring. And if the ABGA score is less than 3, the child will require resuscitation. So usually we will do ABGA score in the first and 5 minutes of life, And however, if the APGAR score is fairly low, we will repeat again in a 10-minute or 30-minute. Right. So before the child was born, we need to assess the risk factor that every pregnant woman have. So we have antepartum risk factor and intrapartum risk factor that may increase the risk of requiring neonatal resuscitation. As we can see in the table, so among the antepartum risk factor include premature or postpartum, mother with disease in pregnancy such as preeclampsia, hypertension, and anemia, and then other fetal conditions such as polyhydramnios, oligohydramnios, and so on. And meanwhile, in the interpartum risk factor, we have a few other things that we need to take note of. For example, emergency cesarean section, assisted delivery with forceps or vacuum, and if the mother required anesthesia or opioid, and if the mother was on magnesium therapy. In addition to that, we need to also take note if the liquor during labor, whether it is contaminated with meconium or if there is present or less umbilical cord. Okay, these are among a few causes of infant that born inactive. It can be due to respiratory causes, cardiac causes, neurological, or other. So in respiratory causes, it may be due to respiratory distress syndrome. So respiratory syndrome or other name is hyaline membrane disease, which usually happen in a child that was born premature, where there will be a reduced production of surfactant, which impair the respiration of the child. And the second one is for meconium aspiration, when there is the liquor was stained with meconium or fecal matter of the baby, which will cause when the baby ingest the liquor, it will obstruct the respiratory tract. The next one is transient tachypnea of newborn, where it is actually a self-limiting condition. In a simple word, transient tachypnea of newborn is condition where there is a delay in clearance in the fetal lung liquid, liquor in the fetal lung. So usually this condition happen in the child that born with via emergency cesarean section. Because if the child was born via spontaneous vaginal delivery, the step of evacuation of the child through the vagina will assist the clearance of fluid from the lung. Okay. So and then for birth asphyxia, it may be due to cord prolapse or placenta rupture or placenta insufficiency. Right. So aside from that, there are a few other causes that I would like to touch on. For example, neurological encephalopathy, specifically on hypoxic ischemic encephalopathy. So it is actually a brain injury due to oxygen deprivation. So as you guys can see in the table here, this is the criteria to diagnose hypoxic ischemic encephalopathy. So there are 3 criteria that need to be met to say that the child is having hypoxic ischemic encephalopathy. So the first one, there's a lead onset of encephalopathy. The second one is neonatal sign, at least 3 of these 5, of these 6. And the third one is absence of any other causes. All right. So the next one is neonatal hypoglycemia, which is also another cause that can lead the child to be born inactive. So it is defined as reduced plasma glucose, which can cause a symptom and sign of brain impairment, which may cause symptoms and sign of brain impairment. So the pathophysiology behind it actually is because it usually happen in the a pregnant mother with gestational diabetes mellitus. As we know, when when the mother has gestational diabetes mellitus, so the child, especially if it is uncontrolled, so the child is exposed to high concentration of glucose. So the pancreas of the child will start to produce insulin, and then when to convert the glucose. So when the child was born, so there will be no supply of glucose from the mother, but the child still produce the insulin. So this will lead to neonatal hypoglycemia. So the normal plasma glucose level is 2 at least more than 2.6 for both term and preterm. So among the signs of hypoglycemia, as we can see, include cyanosis, seizure, tachypnea, and other features in the abdomen. All right. So aside from that, sepsis and drug or medication induced can also lead to child-born inactive. So in the sepsis, it can be local or systemic. Usually it's systemic, and usually it's more prone to happen in child which was born premature. And according to study, the child that was born premature has around 6 times more risk to have sepsis, congenital sepsis. Okay, so among the signs of the sepsis, as we all know, so there will be hypothermia, there will be changes in the child behavior, and then and there other cardiovascular symptoms such as tachycardia and hypertension, and respiratory, the patient can have cyanosis, tachypnea, and respiratory distress. All right. As the next one is drug or medication induced. So this one we have under drug or medication induced, we have a condition called neonatal withdrawal or neonatal absence syndrome, where uh, when based on the history, if the patient have exposure, if the mother take any drugs or medication during pregnancy. So this neonatal withdrawal syndrome usually occur around 24 to 48 hours after birth when the exposure will stop. So for the drug or medication induced, we need to ask the mother about the history of drug or medication induced during their pregnancy. Right. So next after that, so after we know the causes, so these are the step of investigation that we do for every children that was born. So we first see the general observation, then we assess the head and neck. So I'm not and then we assess the chest, abdomen, hip, genitalia, and last we assess the limb, spine, and central nervous system. Okay, so I think this one because this one I will not touch more in detail, because we have a session with Dr. Mossad which teach the physical examination and newborn. Right. So these are the tests, the investigation that we will do. So we will do full blood count to check if there is evidence of infection, evidence by raise in white blood cell count and white blood cell differential, and then if the patient have anemia, which might suggest any blood loss, then we also check the coagulation profile and renal profile. And then we also test for liver function test, because it is one of the clinical sign in to diagnose FISH-IE. Then we also take the blood glucose to check the glucose level to exclude hypoglycemia. Then we also take the actual blood gases to exclude respiratory and metabolic acidosis, and we also do blood culture to detect causative organism. As for the imaging, we can do chest X-ray to exclude to see if there is any features that suggest respiratory causes, ultrasound of the head, and then echocardiogram to exclude the congenital heart diseases, and MRI brain brain. So lastly, this is the algorithm for neonatal resuscitation. So I'll just go briefly. So when the child was born, before the child was born, so we will have antenatal counseling. Then when we need to know the child was born term or not, whether the child have good tone, and whether the child was breathing or crying. And then if yes, then we'll send the child to the mother, and we will do routine care. And if no, we will see whether the child is apnea or gasping, and the child's respiratory rate. And then if the respiratory rate is less than 100, so we will do pulse oximetry and do cardiac monitoring. Okay. So if heart rate is persistently less than 100, so we will ensure adequate ventilation, and we will consider ETT or laryngeal mask and also cardiac monitoring. Then we see again the heart rate. So if already raised more than 100, and then we do post-resuscitative care. But if it is decreasing, we will follow the flow in the algorithm. All right. So I think that's all from me. Dr. You
Sorry. Okay. So what I'm trying to say is actually it's a quite good, very good presentation. So what the topic that we have discussed actually not just a matter of for exam, right? These are things that you will be facing when you start working. So keep this in mind. What how we approach this, and not mainly for example. Again, these are things that you come across day and day when you work. Okay, so especially in the last topic like in active baby, if you have a chance, you're gonna have chance either in pediatric or in OAG. Right, in pediatrics, always try to look when they go for baby screening. Houseman, when you go for baby screening, just try to accompany them, and you got a chance take turn to go to OT when they attend emergency Caesar or even elective Caesar. Then in ONG, you repeat this again. So you will then appreciate what we have discussed. Okay, so you'll be seeing and doing a bit more when you're doing NICU attachment, like what you have discussed. So very good, quite clear. Any question about the first two presentation? The third one is again very good. Okay, about the urine color. Is again same question in will be asked in your clinical examination, right? Intravascular, extravascular hemolysis is very common. Again and again, the question will come. Okay. So any concern? I think it's quite clear, straightforward. I think you should revise, and you have any problem, you can go back to the presenter presenting the topic. They have presented this in a very clear and concise manner. Very good. Okay. So any concern, any issue? All right. Kalau tak ada, I think again, please email me the presentation for safekeeping. And again, you should. This is actually a very good slides. You should keep this even in those who are going for their later postgraduate. I think this is again same thing. I know it's very early, but the way that you are discussing and presenting is what usually the flow that we going to ask you in exam. Third year, fourth year, final year, postgrad sama je. Okay, so just keep the slide that we have discussed this. Okay, pada tadi kita end up with tasbih kifarah Saras. Okay, alright. Assalamualaikum warahmatullahi wabarakatuh. Sorry again tadi ada emergency lambat. Okay. Assalamualaikum.
Good.